and we're going to get right into the questions. When we originally planned this roundtable, it was actually supposed to be held today in Milwaukee. So I'm really, really sorry that we weren't able to visit and see each other, but I am glad we were able to see each other in this way. So I'd like to just start out with a couple of 3 questions, and then I'm going to hand it over to Jenny. First question is, for second or third line patients, as of now, do you recommend an immunotherapy trial or traditional triplet like daratumumab or elotuzumab? And if so, explain why.
I can answer that. Well, we always recommend clinical trials, of course, because I think they provide valuable opportunities for patients. But in the absence of one, the immunotherapies are generally in this situation only in clinical trials, particularly if you're thinking about second or third line. There's just a few trials that are looking at these agents in second or third line. And so if you're not going to do a clinical trial because it just isn't in the cards, then I think that discussion becomes complicated because there are drugs like daratumumab and carfilzomib, which tend to be used in the second and third lines, but it all depends on what you had before, how you felt with it, what your other comorbidities or other conditions are. And those are the things that you and your doctor will use to make a decision about the best second or third line option.
Yeah, and the other point is that for second or third line, even the immunotherapy clinical trials are not straightforward immunotherapy. It's immunotherapy versus one of these 3 drug combinations. That's the way these trials are defined, because in that setting, the standard of care is to do the 3 drug combination. So the immunotherapy is always in a comparison trial. So you might have a 50-50 chance or something of getting on the immunotherapy as such.
Okay. Dr. Zonder, do you have anything to add to that?
I would just say that, outside of the setting of a clinical trial, I completely agree with what Dr. Shah said about, the utility of clinical trials. And we, like most large myeloma programs, we are proponents of clinical research for sure. But outside of the setting of a clinical trial, I think it's increasingly common for patients to continue to get triplet-based therapy of some sort through first, second, and third line of therapy. But at each step, you're always asking yourself, the decision between a triplet versus a doublet, it always comes down to, is there a reason why this patient shouldn't have a triplet? Is there something about this specific patient situation, or as you sort of move through therapies, is there something that we learned from past lines with this person that makes, that identifies them as maybe somebody that we want to go, with a milder regimen. So it is patient specific. It's how did they respond to previous therapies? When was the last time they had those therapies? Were they refractory when they stopped them? And how did they tolerate them? So there's a lot. There's a lot that goes into the decision.
Okay. This is a question from Mamdu and also an anonymous contributor. Is Darzalex subcutaneous as effective as the infusion form? And how does it compare with isatuxumab?
So I can take that because, all the studies that we have done so far suggest that Darzalex subcutaneous is equally effective as Darzalex IV. There are no head-to-head comparison with Darzalex and isatuxumab, so it's difficult to say which one is more effective. Most of us believe they are equally effective. What we really don't know is if people who have failed one will respond to the other. It may be worth exploring that if you have no other options to explore, but right now we have no idea. If you failed Darzalex, are you going to respond to isatuxumab, and vice versa? If you failed isatuxumab, are you going to respond to Darzalex? But the sub-Q and IV are quite clearly equal.
I would add to that, at least in my own practice, and I think I would imagine it's going to be the same for all these speakers. It's common to re-challenge patients with the same drugs, including daratumumab. But in the case of CD38 antibodies, if you're going to re-challenge with Dara or move from Dara to isatuxumab, typically there's a break in between. You don't roll from one Dara regimen to another Dara regimen. Usually there's some sort of reset period where there's other interim treatments, and then maybe come back to a CD38 antibody later. And which one is better, a re-challenge of the same or moving to the other? I think there's no data.
We've had a number of questions asked about amyloidosis. Daniel asks, for a newly diagnosed patient with AL amyloidosis, which drug is better for induction therapy and why? And if you could, please compare and contrast cyclophosphamide with Revlimid.
Oh, well, so there's no consensus on standard. I would say internationally, the most commonly used frontline regimen is Cybor-D. So wait, the comparison they wanted was
between excuse me, cyclophosphamide and Revlimid.
So there was an interesting series from Greece that looked at RVD up front, and the response rates were high, but it was a difficult regimen to give, and that's actually been our experience also with a pomalidomide study. That IMiDs just require a lot of attention to detail, often require dose reductions or interruptions, and so they're just not as easy to use as alkylating agents. And so, cyclophosphamide is the partner for Velcade, or melphalan as the partner for Velcade, frankly, is a bit easier and so more commonly used. But Revlimid and pomalidomide do have a role in the disease. It's just, it's not as easy as it is with myeloma.
Okay. Jenny has a couple of questions. You need your mic on.
That always helps. So Adrian asked the question, what are the currently available most precise genetic sequencing tests or protocols that can help decide treatment? Now that things like venetoclax are around, or all these other immunotherapies are opening up.
Well, I do want to say one comment about genetics and immunotherapy, because this does tend to come up, which is that we just don't know. And the immunotherapy trials right now are just focusing on people with very active relapse refractory myeloma, and those people have a whole different bunch of genetic diversities. So it's impossible to say that one therapy is good for a certain for a certain genetic change. And I think I would say the only therapy we have that is directed towards a genetic change is venetoclax. That's my opinion.
Right. I agree, and that is an example of one where you're basing that decision on standard cytogenetics in fish. That's not really molecular profiling. There are other targeted agents like BRAF inhibitors, IDH1 and 2 inhibitors, which may have utility in a small subset of patients, but you have to do molecular profiling, looking for mutated targets. Not just expression of them, but mutated targets, activating mutations and things like that.
Mm-hmm. And Claudia asked kind of a related question, that if she doesn't have any gene mutations at diagnosis, might she develop them later?
Yes, it is possible in myeloma to acquire mutations. We call that clonal evolution. So a person can acquire mutations later. And just to expand upon what Dr. Zonder and Dr. Shah said, for patients who have multiple relapse myeloma, you need a molecular next generation sequencing type of test. And for people who are newly diagnosed, we have gene expression profiling tests that can give you a little bit more resolution than the standard FISH test. So both of those are available. Again, if there are no options, and if you're at advanced stage of myeloma, doing a next generation sequencing sometimes, not all the time, sometimes might give you an actionable mutation. But again, we just don't have the data to actually say what percentage of patients will benefit. We just don't have that.
And I think this is one of the reasons why trials like My Drug were invented, really to see if you can use the information from genetic testing to take action on that. And sometimes I think myeloma is like the lung cancer of hematologic malignancies. There's so many mutations, and it's like a whack-a-mole. You do one, something else is going to pop up, and that's been shown in other studies as well. So we have a long way to go as far as analyzing genetic mutations and taking action on them.
And it's becoming an increasingly common idea to look for to do this kind of molecular profiling. There are commercially available assays out there, and even community practices, off-label, use of medications to target actionable mutations is being undertaken. And I guess a word of caution is that because of this idea of clonal evolution that we were just talking about, it's really important not to make those kinds of off-label targeted decisions on old bone marrow biopsies. I mean, I think you need to know what your current molecular profile is like if you're going to consider doing that. You don't want to use a 3-year-old bone marrow biopsy that showed a specific abnormality. When you're looking at starting a very narrowly targeted agent, you want to make sure that that target is still there.
Mm-hmm. Great. Greg, do you want to ask?
Yes, I'll ask one and then I'll send it back to you. We have a question from Ira for Dr. Zonder. Can you give us any insight why SAP scintigraphy, I hope I said that right, is regularly performed in England but not in the US, especially since it identifies amyloid fibril distribution in the body?
Yes. Why it's in use in England and not in the United States is somewhat of a long story. But in terms of the utility of the test, that's somewhat debatable. It's at best a very semi-quantitative form of imaging that may not image all organs equally well. The resolution is very modest, and you need fairly large amyloid burden within an organ for it to light up. What it's targeting, SAP is a different protein that gets incorporated into amyloid fibrils, and remember before I mentioned that like different types of amyloid, the amyloid fibrils are built of different types of protein building blocks, but there are these other proteins that are incorporated into like the scaffolding of the fibrils that may be common across different subtypes of amyloid, and SAP is one of them. And so SAP, labeled SAP antibodies as an imaging modality, and also antibodies targeting SAP as a form of treatment have both been explored to differing degrees. The anti-SAP antibodies as therapy made it as far as phase 2 studies in the United States in cardiac patients. And because of some complications that occurred early on that caused the company working on that to sort of reevaluate the risk-benefit profile, they sort of shelved that project. And so anti-SAP antibodies as therapy aren't moving forward. But a SAP scan doesn't provide the kind of resolution as say like a PET CT scan does for looking at bone disease. So it's to be honest, it would be unusual to make a clinical decision based on the results of a SAP scan, and I don't think it has a future, as an imaging modality here at all.
Okay, thank you.
Great. We got a question from an email also from Marianne, and she says, some myeloma survivors have spoken about research about transplant patients. And in the first section, we talked quite a bit about transplant, but I'd like this second group to address this also. What is your opinion on undergoing stem cell transplant upfront, or leave it for when there are no other options?
Well, I think definitely for Hari and me, preaching to the choir, but I've always been a huge fan of transplant. And the reason for this is that it allows for a really one-time therapy with the mechanism of action that is traditionally not already seen by the myeloma patients by this time. Many of them get VRD, and then melphalan is a totally different drug. And it's a drug that does a really good job at digging out that myeloma. So I'm a fan of doing transplant generally upfront where we have the most amount of data. I also agree, I think somebody else said before, I think Natalie said that if you've had a transplant and then a long-term recovery, then doing one 5 years down the line, I've also done that many times. Again, to get the patient in a place where maybe after transplant, they can just be on pomalidomide on maintenance or something small, but not on weeks and weeks and weeks of chemotherapy. So it just depends on the patient. And then if you decided not to get a transplant, that's fine too. And maybe down the line, you may be a candidate or want to get a transplant. I generally, especially for my 60-year-olds and higher, try to do it earlier. But it can be done at any time. I just favor doing early.
Hari, do you want to weigh in?
Yeah, I completely agree with Nina on that. So at this time, we can only base our answers on what is known at this time. At this time, to get a long remission from your first treatment, the best option is to have a transplant. That has been tested since about 1995. That's almost 25 years of testing that hypothesis against various chemos, various combination regimens. And every time we test it, we find the same thing over and over again. To get your long remission from your first treatment, a transplant is the best option. However, it's okay to defer transplant. In that case, please collect cells so that you can do it later at relapse, but the relapse is going to come sooner than if you had a transplant. And then there are, doing a transplant confers some advantages. If you're going to have a transplant in your life, better to do it when you're younger and healthier than wait for later and when you are older. So all of that points to the fact that at this time, we have to make that judgment. Maybe in 5 to 10 years, we might find CAR-Ts or something upfront that might replace transplant. But even then, it is an effective therapy, and some patients will always need transplants.
Now, can I just say something? This is Natalie. Sorry to bug in for a second. I think we're all going to be very interested to see the results from the endurance trial that's going to come out in ASCO. So this is a trial where transplant was deliberately delayed, that patients got 9 months of induction with either VRD or KRD plus len maintenance. And I think it'll be very interesting to see what the PFS is for that group of patients if you compare it to, say, one of the more recent transplant trials, that we can take a look at that and kind of get an idea about who's got some better control with just a chemo-only approach versus transplant.
I would also add, in response to the specific question that was asked about upfront versus waiting until I think the wording was all other options were exhausted. And actually, I strongly discourage that particular strategy. I think when most of us are talking about delayed transplant, we are not talking about using it as 7th-line therapy for the first time. I think we're talking about using it at first or at the latest second relapse. Because you will, as Hari said, patients tend to be less healthy as they go further through things. And also the disease becomes more resistant. And so you get less out of, you get more toxicity and less efficacy the deeper that you go. There's not a huge difference in efficacy and toxicity when you're using it as 2nd-line therapy compared to first, but there is when you're using it as 7th-line therapy compared to first. And so that's a particularly, I think, a bad use of stem cells is to wait to use them for that long. So there's just my 2 cents. I mean, a delayed transplant really should mean first or second relapse, in my opinion.
Right, and Vicky had a comment also that she collected stem cells 15 years ago, and now they're no longer viable. So what's the likelihood of her being able to collect stem cells?
Well, I had answered this also because it's possible that stem cells are viable. And one way you can know that is to do a colony forming unit assay, which your stem cell lab can possibly do. And if those assays are normal, I think it's possible that those stem cells are active, are still good. Recollecting a second time, I've done that a handful of times. It does work for some patients, not a guarantee, but it's not, all is not lost, and it's worth checking out those stem cells to see if they're still good.
Okay, good answer. Thank you. Greg, do you want to?
Yeah, Jay asks, is it possible to have a stringent complete response for myeloma and less than a complete response for amyloidosis?
The answer is yes, in a certain sense, right? So remember I said that we measure response according to 2 different criteria. There's the hematologic response, and then there's the organ response. And so actually the definition of stringent complete response for myeloma would meet the definition of a complete response hematologically for amyloidosis as well. And that that, stringent complete response means the light chains have basically normalized or better than normal, lower than normal. And so that's, that would be considered a great hematologic response in amyloidosis, but that doesn't mean that organ function is going to be immediately better. And patients may still have significant, organ injury that needs to hopefully work itself out over time while the patient is enjoying that, that deep light chain reduction.
Okay, great. We also had a question about specific to COVID from Paul. Would the use of IVIG basically benefit myeloma patients who contract it? Would it make it worse? Increasing neutrophils direct or preventing secondary infections, is that helpful?
So the NIH consensus guidelines on COVID suggest that IVIG should not be considered a protective for COVID. And it's not logical to consider that because IVIG is pooled immunoglobulin from normal people. And there is not enough people who have donated immunoglobulin that have been exposed to COVID in the past. In the future, it might be that regular IVIG may have some COVID antibodies. Right now, you cannot expect IVIG to confer COVID-specific immunity.
Mm-hmm. Okay, great. Steve also asked about this was a broad question about bone damage in general because we talked a little bit about bone damage at the beginning. Do bone lesions heal after treatment?
If yes, very gradually and generally minimally. I think a general philosophy or accepted reality is that the bone lesions you develop are the bone lesions you're stuck with. The goal of effective therapy, when we consider response and we talk about confirming a complete response or a partial response, the repeat imaging that we do is to confirm that there are no new bone lesions or that the existing bone lesions didn't get bigger, but it does not demand that old bone lesions go away because they usually don't.
Okay. And Dr. Shah, you answered some of these questions already from Sharon, but she was just wondering about the CAR-Ts and BiTEs, and you gave a nice differentiation between those two, and just length of remission. Is that a consideration, or do you more look at other factors like can you get it in the setting, is it off the shelf, or have you looked at that at all, or do you consider that?
Yeah, well, we don't know exactly the length of remission between all of the CAR-T versus BiTE. I mean, that data is pretty young still, and we only have gotten long-term data on really 2 CAR-T products. So that's pending. But I think one of the things that's going to play into our decision-making in the future is this off-the-shelf versus manufactured issue. And there are some people that want to go to a specialized center, like a transplant center, for example, and they'd have already and get the CAR-T. And what I love about CAR-T, if it works great, and it's one therapy and you don't have to get cycles and cycles of chemo. But of course, on the flip side, not everybody can go to a center and do all these things. And so there may be people who prefer to get one dose of bispecific therapy at the center, just that one dose, go back home and get it more frequently with their local provider, and that's fine too. And I think that's why we're not going to be able to say it's this one versus it's this one over that one, but it will just be more tuned to the patient's own profile.
Mm-hmm. Great. Greg, do you want to tackle that?
Yes, Jill asks 2 questions about amyloidosis. It's her understanding that amyloidosis typically has lambda light chains. How frequently are kappa light chains involved? And her other question is, do you ever see improvements in organ function after treatment for AL amyloidosis?
So she's right. It is more commonly lambda light chain type. Compared to myeloma, it's about the ratio is flipped. So in myeloma, about 2/3 of patients have a kappa restricted M protein or light chains, and only 1/3 are lambda, and it's vice versa in amyloid. About 2/3 of patients are lambda light chain subtype. And as far as organ response, yes, I mean, we do see improvements in organ function. There is a subset of patients who get fairly quick improvements in heart or kidney function. And we think that has to do with the actual direct toxicity. Remember I said there's 2 different steps to that toxic protein formation. There's the soluble light chains they start forming small misfolded clumps that are still soluble. And then those drop out into these tissue deposits, and that's the next step. Those are the fibrils. Reduction of that soluble fraction, which happens fairly immediately with treatment, just like lowering light chains occurs fairly immediately. Sometimes patients actually do get an improvement in cardiac functionality, for instance. But in terms of, most organ responses take longer than that and have to do with clearance probably of the amyloid deposits in the organ themselves. And, I think most people feel about a third of patients will actually have improvement in heart or kidney function, although a sizable percentage of patients may have stabilization of dysfunction without further worsening if you can lower the light chain sufficiently.
Okay. Another question, great, thank you. Another question on genetics. Does the P53 mutation ever go away or change once you have acquired it?
It's a little complicated explanation. So you have to understand that the P53 mutation is in a clone of myeloma cells. In fact, so if the patient has a bunch of myeloma cells that carry this mutation, with treatment, and if you successfully eradicate that, it can go away. And when the patient relapses, or if they relapse the next time, it can be with the same clone that still carries the P53 mutation, which is more likely, or it can be with a different clone that does not carry the P53 mutation. So the answer to that question is, it is possible that somebody had a P53 mutation and it went away and it never relapsed. That's possible. In that case, it's gone away. It's possible that the P53 clone got destroyed and at some point later it came back and then it is still there. And third option is that it went away, and when the relapse happened, it was a different clone which did not carry the P53 mutation. So all three are possibilities.
Anybody else want to weigh in? Or okay, that's a great answer. The genetics are confusing. I have a question from Joanne. As a high-risk smoldering myeloma patient, should you go ahead and get a stem cell transplant?
I can take this one. So if there's anything that's controversial, I'd say in myeloma, it's smoldering myeloma, because we all talk about it. So right now, the teaching is for high-risk smoldering myeloma, I think the best thing is a clinical trial, and that's not a cop-out. That's just the truth, because we don't know the answer. And although there were benefits of progression-free survival, meaning that the time to developing myeloma symptoms that required treatment was less for people who got treatment for their smoldering myeloma in the recent ECOG trial, we do not yet know if that changes overall survival, which is the total length of time that a person is alive. And I am a self-proclaimed quality of life girl, and I often choose quality of life over everything else because that's so important to me and to many of my patients. And if it is important to the patient, then I try to hold off on treatment for smoldering myeloma unless it's in a clinical trial. And I think that is fine. Because we really don't know the answer. But I wouldn't necessarily commit my patient, even with high-risk smoldering myeloma, to full treatment and a trial and transplant, because it might be that that person could have waited 2 years, not been on therapy, and had the same outcome as far as number of years living. And in the meantime, could have been hanging with their family and doing other things. So I don't commit them to that off clinical trial. That's my opinion.
And another follow-up question that maybe the other panelists can answer in addition to what Dr. Shah just addressed is that if you're in CR and you're MRD negative, should you continue and go to transplant? Or Dr. Shah, you can start too. Or address that.
Yeah, you guys talk about the smoldering in that.
Yeah, I can answer in a general way. I can answer that question. It was touched on earlier, I think, in the other panel, but the fact is we don't know yet if you can use MRD negativity or any degree of response status to guide the length of treatment. I think most of us tend to continue maintenance therapy on an ongoing basis if it's working. But if, and are particularly reluctant to discontinue it in patients who've had just like a very partial response. If there's a subset of patients where you could think about stopping maintenance therapy, and this is just maintenance therapy, the question you asked was about transplant, which is a whole nother level. But if there was a subset you'd ever wonder about being able to stop therapy, and I would say that it's patients who are MRD negative. The little bit of data that we have on this question relates to a KRD study, and if I'm remembering the data correctly, the depth of MRD negativity when it was measured by a couple of different assays was actually deeper with transplant. And so, when we talk about MRD, one of the difficulties in the field, right, is that, some of the studies that have looked at MRD negativity used, an assay that was sensitive to detect 1 cell out of 10,000. And some used 1 out of 100,000, and another study will use an assay that detects 1 out of 1,000,000 cells in the bone marrow. And those actually, it turns out, mean different things. And so you have a higher percentage of patients with full intensity therapy. You have a higher percentage of patients who go from that sort of like barely qualifying as having MRD using the less sensitive assays to having the deeper MRD, and deeper MRD is better. So I think right now, particularly since there's no standardization of MRD testing, in practice, although it's tempting, most of us aren't using MRD negativity as a go, no go for transplant decision. We believe that it pushes some patients from a, sort of a substandard MRD to the best level of MRD with the high dose therapy.
Okay, great. Any other comments?
I completely agree with Dr. Saunders.
Okay, Dottie asks, she says that the steroid dexamethasone has kind of ruined her adrenal gland and caused like Cushing's disease-like symptoms. So she's wondering if there are any treatment combinations that are without the dex. And then she's already had 2 stem cell transplants, so can she get a third, but she hasn't collected enough stem cells for a third?
Rarely some patients do get a third transplant, but these are patients who have had substantial remissions, and sometimes we use a third transplant just to get good cell count so that they can join a clinical trial, etc. So a third transplant is done. I think we looked at the CIB-MTR database, and we have probably like 150 patients who've had a third transplant within the last 10 years. So it's a small number out of some 6,000 patients every year who get a first transplant. So that's a small number of patients. But again, when we do a third transplant, it's usually to get some good cell count so that they can join a clinical trial, etc. But for the other question, steroid-free regimens. So one of the attractions with a lot of these immunotherapies is that we actually discourage, and we don't want steroids with them. So that would be the best hope. For CAR T cells, we don't use steroids unless patients get neurotoxicity. For bites, we actually typically have tried to avoid high-dose steroids. So those are the emerging, highly effective therapies that do not have steroids. But if she works with her doctor, we can sometimes come up with minimally steroid-containing regimens or completely steroid-free regimens. For example, an old-fashioned regimen, there's something called Velcade Doxil that does not use any steroids. There's traditional chemo, but it's not necessarily any easier than steroid-containing regimens. So be working with your doctor to get a regimen that uses minimal steroids, or going for a clinical trial that involves some form of immunotherapy where there is no steroids.
Yeah,
I think all patients hate steroids.
Usually it's a modification of an existing regimen. At our center, we actually have a regimen we call Cyborg No-D. Which is basically just Cytoxan and Velcade without dexamethasone. And that's, everybody, all of us know what we're talking about internally when we refer to it as that, including the pharmacists. Like, it's just, there are some patients who, have had prior exposure to steroids, and they know, and they don't tolerate them very well. And sometimes you just have to modify a regimen to exclude them.
Mm-hmm. Dr. Shaw, do you have any other comments on this? I think we're going to make this our last question just because we're out of time.
No, I agree with what everybody said. And I think steroids are tough, and I routinely decrease them after a few cycles for relapse patients. It's just too much.
Mm-hmm. Okay. Well, it's been an amazing day, and you are so fabulous. Dr. Hari and Dr. Zonder and Dr. Shaw, thank you so much for joining us. We're so thrilled that you were able to answer. And Dr. Callender, thank you for hanging in with us there all day. Oh my gosh, it's a lot of myeloma. But I just want to reiterate that the importance of seeing a myeloma specialist. As you can see, there are a lot of nuanced questions that patients need answered. And in my opinion, it really requires a myeloma specialist on your team. So please, please, please have a myeloma specialist consulting with you. And if you need to get care somewhere else, do it. But I think telemedicine will open things up and you're going to see lots of changes, in my opinion. So thank you, Greg, for organizing this meeting and assembling this amazing faculty for us. Thank you to all the faculty and thank you to our viewers.
Thank you.
So
Thanks for having us.
Thank you.